Welcome Dr. Gitanjali, new passionate regional anesthetist.
Hello. Good morning. I'm Dr. Gitanjali Akhade. I'm consultant in Noble Hospital, Pune. So my topic is block on arrival or on arrival block. Lessons on do's and don'ts. Going to the introduction. Early and efficient resuscitation. These are the key factors in obtaining good outcomes for major trauma. On arrival block, wherein the peripheral nerve block is given to severely injured extremity. In short, the hospital arrival to surgery time that is shortened. Early management in this dramatic period, in patient's passage to the any surgical unit, it is cut short. So there is a rapid pain relief, which is the first step of the management protocol in the main operating room. So they are bypassing the emergency department, and the patient is directly shifted to the operation theatre or the side room of the operation theatre. It is found to be a game changer in trauma care. The anesthesiologist and the surgeon, they work together, and these are the key members for the first assessment and management team in the main operating room. This on-arrival block, that concept was set up in Ganga Hospital, where I did my fellowship in regional anesthesia. That concept was developed by Dr. Bhatt. He was the chief anesthesiologist, and it was in early 90s, along with Dr. Raja Sabhapati, the plastic surgeon. They recognize its value because lots of trauma patients are coming to the Ganga Hospital. So it was developed as a part of overall system of the trauma care. This system established a development of system of care. This block was given in the main operation theatre room instead of in the emergency department. So the initial assessment, resuscitation and further management of the patient, it was followed simultaneously along with this on-arrival block. So emergency resuscitation in the emergency room, it was bypassed. Patient assessment, resuscitation, it is only once instead of twice. So there was time was saved. The radiographs were taken after on-arrival block. The bandages were removed, which avoids the overlapping of the fractured bone. And the patient was assessed and immediately taken to the surgery. This is a design of this on-arrival block system in Ganga Hospital, where the trauma patient arrives in the emergency room, where the primary survey, ATLS survey is done, and immediately transferred to the room adjacent to the operation theatre, which is called as a block room or the resuscitation room. The patient is received by senior anesthesiologist and senior plastic surgeon. The senior anesthesiologist does the primary assessment, rules out any brachial plexus injury. On-arrival block is given, and the simultaneous resuscitation is going on. Dressings are removed, exploration of the wound is done, tourniquets are applied to control the bleeding, and the surgery is carried out if the patient is eligible for that surgery. So these are the pictures taken from the Ganga Hospital, how the on-arrival block was given. So what are the benefits of this on-arrival block? The benefits are it provides superior, fast, effective, highly specific analgesia. It decreases the stress response, decreases catecholamines, interleukin 6. It will reduce the anxiety of the patient, and the patient will develop this faith on the system. Patient will cooperate. The tourniquet application is possible without causing pain to the patient, and so the initial dressing removal and the assessment of the bleeding and wound exploration, that is also possible. It interrupts the injury related vasospasm, and it allows the maximum vasodilatation of the digits for replantation. And the main advantage is that it avoids the patient landing into the chronic pain. Why peripheral nerve block is used instead of sedation? So what are the advantages over the sedation? It reduces the opioid requirement and also the opioid free analgesia. It is beneficial especially in the elderly patients. It will avoid the cognitive impairment, sedation. It will be easy for the transportation of the patient. The patient's cooperation will be there once the pain is gone. So there will be the clinical evaluation, imaging of the clinical injury, X-ray taking. It will be helpful. It avoids besides that, it avoids the side effects of these opioids like respiratory depression, hemodynamic instability, altered mentation, and delirium. These peripheral nerve blocks, they will reduce the mortality and morbidity which are related to the hip fracture, femur fracture, rib fractures. This analgesic efficacy, it will allow the transport of the patient when arriving at the emergency room. So this block, besides that, this block, it can be used for the definitive surgery if the surgery is carried out, and it will avoid the need for general anesthesia and reduce the respiratory complications. So that was the scenario in Ganga Hospital where the patients were resuscitated in the block room. If you go on reviewing the literature, lots of literature regarding this on-arrival block are there, which mentions that on-arrival blocks are given in the emergency departments. So peripheral nerve blocks for the trauma beyond the operating room settings are already included in the national and the local management guidelines in the North America and Europe. Then American Society of Orthopedic Surgeons, NICE guidelines, and Canadian guidelines, they have included these peripheral nerve blocks as a multimodal analgesia strategies in the emergency room. So these are the evidences where the on-arrival blocks are given in the emergency rooms. So in Ganga, we were mainly giving the on-arrival block, the supraclavicular block, mainly for the upper limb surgeries. Now they are expanding their extensions of logical extension of this on-arrival block, which can be used for lower limb surgeries also. Fracture neck, femur, sharp femurs, knee, ankle dislocations, then foreign body removal of foot, abscess drainage, or crush injuries. It can be used for the truncal blocks, like for the rib fractures. And the literature has mentioned that it can be used for head face surgery, that is scalp blocks. You can use for migraine headache, you can use these blocks. So what are the barriers performing these regional anesthesia blocks in the emergency department? There is a significant variability in the hospital privileging. So pain is not given a priority. There are interdepartmental obstacles. So masking of the consultant's neurological examination in an injured extremity, it is an issue. Interdepartmental protocols, pre-block examination documentation, and there is no specific arrangement. So these are the obstacles in giving the blocks in the emergency room. Apart from that, anesthesiologists are so busy that it becomes it is beyond our capacity to go into the emergency room and giving the block all the time. So this can be overcome by simple design solutions, then giving the training to the emergency physicians about these blocks, and keeping the simple block bags, protocols, keeping the equipment ready. That will avoid all these obstacles or barriers. Potential for multiple absolute or relative contraindications for the regional blocks. They will avoid these regional blocks in the emergency department, like distorted anatomy, coagulopathy, compartment syndrome. The surgeon will resist competition with the resuscitation team objectives because they think that resuscitation, it is the main priority and pain is not given the priority. Lack of appropriate equipment, training, especially in the emergency department and pre-hospital care. And there are case reports which are the main culprit that link between the adverse outcome and the regional anesthesia interventions. So what can we do? So it's our duty that greater recognition of the pain as a disease process that will lead to the functional and psychological outcome if poorly managed, that should be notified to the surgeon. Then there should be proper publication of the guidelines which will address how relative contraindication can be negotiated with the risk-benefit analysis. Then shortcomings and side effects from administration of the local anesthetics, that should be discussed with the surgeons. Then other facilities like ultrasound, that will improve the training and technology, and that will build the faith on our system. There are controversies in this on-arrival block or the regional anesthesia in the emergency department. The controversy, the main is the compartment syndrome. Surgeons are more concerned about this compartment syndrome. That is, regional anesthesia is implicated as one of the delayed cause for delayed diagnosis of the compartment syndrome. But the fact is that pain is the unreliable symptom of this compartment syndrome. There are very few case reports which are relating regional anesthesia to this compartment syndrome. Actually, this regional anesthesia, it facilitates the early detection of the compartment syndrome because there is a breakthrough pain. This anterior compartment mainly is supplied by the peroneal nerve. After giving femoral nerve, it will not be masked. So what should we do? We should use regional anesthesia judiciously, avoid motor block, and just concentrate on the sensory block, pain relief of this patient by reducing the local anesthetic concentration and doses. Avoid dense block and avoid the additives, that is alpha 2 agonist opioids, which are not established. The patient should be monitored for compartment syndrome, that is the pressure should be monitored. The other causes has to be ruled out, that is because of the cast or because of the positioning, that can lead to compartment syndrome. The discussion between the surgeon and the anesthesiologist should occur before the regional block in the high risk situations. Peripheral nerve blocks provide the targeted analgesia and it may permit early detection of the compartment syndrome in the territories of the unblocked nodes. The second concern is about the pre-existing nerve injury. There is a concept of double crush syndrome. There is a pre-existing nerve injury, and if we give regional anesthesia, and that can lead to exposure to the secondary insult. So it can cause a neurological deficit. So individual risk-benefit analysis discussion, it is essential. We have to modify our technique by using less potent local analgesics, reducing volume, concentration, avoiding vasoconstrictors. And most important factor is before performing block, there should be a detailed neurological examination. There should be the documentation of the findings for medical legal purposes if the patient is having the neurological deficit. The third concern is about the anticoagulation. These patients, when they are coming to the emergency room, they are in trauma, they are having crush injury, bleeding patients. These patients are not evaluated for their coagulation profile. We don't know the coagulation profile of these patients. Apart from that, the trauma predisposes to both bleeding as well as the thrombosis. The mechanism, the patients are on medications. Multiple factors are responsible, apart hypothermia, hemorrhage, that leads to the coagulopathy. So in these patients, the superficial approaches of the peripheral nerve blocks, these are very safe. That will avoid the vascular structures through the ultrasound guidance, and this is the safer option in the patients on anticoagulation. So recently, European Journal has published this list of the blocks which are superficial, distinguishing which are the deep blocks and which are the superficial blocks. In the list of the deep blocks, spinal, epidural, paravertebral block, multiple blocks are mentioned. So we have to avoid all these blocks in the emergency room. But the supraclavicular blocks, axillary block, then interscalene block, interfacial plane blocks, these are considered to be the superficial blocks and safe block, and these can be given in the emergency room to decrease the pain of the patient. Which are the commonly performed types of the regional anesthesia in the emergency department? For upper limb, superficial cervical plexus, supraclavicular, interscalene, axillary, and for the forearm blocks, that is selective radial, median, ulnar, this can be done. In the lower limb, femoral nerve block, fascia iliaca block, peng block, superficial posterior tibial block. In this, they have not mentioned the lumbar block, lumbar plexus block, quadratus lumborum block. All these blocks are the deep block, and that should be avoided. In truncal block, pec block, erector spinae, serratus anterior plane block, tab block, these can be given. I'll not go in detail about each block, just focusing. For upper extremity, all these blocks, interscalene, supraclavicular, with the less volume and of this local anesthetic and low concentration of the local anesthetic can be used. For the lower extremity hip fracture, So this is from our hospital. Go to the previous slide. Previous slide. नहीं. So in this lower extremity block, hip fractures, it is the most common casualty, especially falls, and the patients are elderly victims. These older patients are with the multiple comorbidities, placing them in the higher risk of complications. The pain intensity is moderate to severe, so this patient should be given analgesia in the emergency room. So that will decrease their stress response. That will help them to settle in the settle for their mental preparation for the surgery also. These peripheral blocks which are advised in this lower extremity hip fractures are the femoral nerve block, fascia iliaca compartmental block, and the pain block. So in lower extremity block, mostly common performed blocks are the femoral nerve block and the fascia iliaca compartment block, which are this is the comparative stages. Both are safe, which give rapid and definitive pain relief. Serious side effects are less commonly. In fascia iliaca block, it is more safer than the femoral nerve block because the puncture site it is distant from the neurovascular sheath, and so it gives the additional margin of safety. The nerve stimulator is not necessary. It can be given by the blind technique or with the ultrasound guided technique. So this is about the fascia iliaca compartment block. Coming to the analgesia for the rib fracture, there are multiple analgesic modalities which are described. Like apart from epidural, thoracic paravertebral, intercostal nerve block, erectus spinae block, serratus plane block, there is a wrist block, and that is a rhomboid intercostal block. Multiple blocks are mentioned. So there is a dilemma, which block we have to choose. In emergency emergency room, we have to avoid this epidural and thoracic paravertebral because we don't know the coagulation profile. So the erectus spinae block and the serratus anterior plane block, these are the interfacial plane block. These are very easy and these are the safer block. These rib fractures, why the patients are required these blocks? Because rib fractures will compromise their pulmonary function. That will add to hypoxemia and pneumonia. Patient may require the mechanical ventilation if the pain is not relieved. Adequate analgesia, it allows the patient to breathe deeply, avoid intubation, clear the secretions effectively. It will help to minimize the pulmonary complications. So in this erectus spinae block, it can be used in the thoracic injury, it can be used in the rib fractures, multiple rib fractures, which are these patients are vulnerable to develop respiratory complications. And the effective analgesia, it will enable the deep breathing, coughing, and early mobilization. It is safe, hemodynamically stable. It provides the hemodynamic stability. It is effective for multiple rib fractures. It is unilateral block because epidural and paravertebral block and the bilateral block. This is the epidural block. It provides target specific. So local anesthetic is injected into the facial planes between the facial planes. It can be given in the patients on anticoagulant medications. This is the serratus anterior plane block, same. That is a simple, safe, and effective block. Local anesthetic is deposited superficial or deep to the serratus anterior muscle. So that will block the lateral cutaneous branches, and this will give analgesia over the anterolateral chest rib fractures. So to develop this on-arrival block system in our emergency room, we have to think about the multidisciplinary approach, training the emergency physicians, training the residents. We have to optimize, refine, and simplify the fundamental techniques. Use the simple techniques. Invest routinely in training and education.
Please conclude.
Develop the clinical pathways.
Please conclude. Thank you.
Thank you, sir.
Thank you, Gitanjali. That was nice, elaborate. On arrival block giving looks very charming and human, but of course there are limitations and concerns which you completely covered in your topic. And I think there is a big role of interfacial plane block where the chances of directly targeting nerves are less. That will remain in the long run, I think so. Plus the limitation of doses to prevent the complications of dose-related complication of local anesthetic, that should be minimized because we don't have a theatre environment on arrival places. So, thank you, Harish. Let's go to Dr. Amin.
Hello. Hello. Am I audible? Thank you, Chairperson, for allowing me. And this is like a point of care ultrasound situation where you have some hitch and you grow. I am thankful and grateful to Dr. Hemant Shinde and Dr. Jiggy Diwatia. He gave me tips about how to use MacBook even more efficiently. And now they have given me Wi-Fi connectivity and I am hands-free. Wow. So now I can handle my slides from here and I can change it. Yeah? So that's the innovation. Any challenging case, you think, you introspect and you move ahead. This is probably, yes, call for help.
And you called who?
Yes, so I have the biggest person to help me here. Yeah, thank you so much. Thank you, chairpersons, for allowing me back here. And thank you, all the audience. They are still here and not at the stalls. So thank you very much. So I was just coming to this ASRA guideline, and I am here to emphasize that ASRA has come up with its own guideline for point of care ultrasound. So if you are thinking that point of care ultrasound is optional, probably days are gone. This article is in 2021. Another 3 years down the line, it will be integral part of all regional anesthesia curriculum, and it will be part of anesthesia curriculum. You will read it in Dorsch, you will read it in probably Miller and Barash-Tolting and Admir Hedzik and everything. So let us prepare ourselves that we deal with this situation aptly in the better interest of the patient. ASRA has come up with the recommendation that at least we should have these following things as basic preparation, and that could be airway ultrasound, lung ultrasound, it is fast gastric ultrasound and cardiac ultrasound. So we have already covered this slide, and what is the evidence also we have seen. So good evidence. So coming to basic fate, I am thinking of severe hypovolemia. Now, I do not need a cardiologist to tell me whether I should give fluids in the recovery room or not. Mr. Modi has said Atmanirbhar Bharat, and in focus we said Atmanirbhar anesthetist. Okay, so we will diagnose our own pneumothorax, we will diagnose whether the patient needs fluid, we will diagnose whether any further cardiological evaluation is required for an obstetric case, something like that. So this is we make our own bread, and this is a subcostal 4-chamber view. Even my PGs are putting the probe here, and when we put a central line, they are very fond of eliciting a swirl sign where they see micro bubbles going from RA to RB in less than 2 seconds. This eyeballing, I was just discussing one day with in my previous institute with in the Ganga hospital, and there the question was, what is the cardiologist actually are doing to the anesthetist? They will just come up and they will write, can be taken up with due risk. So what is this due risk? So then the professor was telling me, थोड़ा सा हमको confidence आता है वो केस करने के लिए, something like that, because it is actually they are writing nothing, they are just taking due risk. So why not do it ourselves, and we should be confident about doing and dealing with these cases. So IVC collapsibility is very important, and just today morning there was a discussion on critically ill patients. So before subjecting our patient for intubation, whether it is obstetric patient or spinal anesthetic, it is very good idea, a very logical step to look at IVC. And this is a common technique where we put it in the subcostal area and we check for IVC. Coming to apical 4-chamber, now the ASRA guidelines are saying that even eyeballing can help you to pick up vegetations on valves. You can, even the local anesthesia systemic toxicity will show regional valve motion abnormalities. And PE, sometimes it is an autopsy diagnosis. We have diagnosed it inside the OT in patients with robotic radical prostatectomy. And what was the first response by the cardiologist, the intensivist? They said, yeah, anesthetist बहुत अच्छे हैं. They are doing the good job because they are treating it well, and there was no doubt about our management. So we do not want an autopsy diagnosis of PE. We just want to fine tune our management, and now it has been come up in the guidelines as well. Coming to lung ultrasound, some few basic tips and tricks. An anesthetist must know how to diagnose pneumothorax. We do many blocks. There are many surgeries with laparoscopy and all that where there are problems. B lines and pulmonary edema is integral part at the end of surgery. Should I give Lasix? Should I give mannitol? Is it good idea to extubate this patient? Have I overdone? Have I underdone? Is the patient catheterized? There is no urine. Is the catheter blocked? Let's put a probe on the bladder and check. Even with IRAS protocol, we are regularly putting and checking the bladder volume and deciding whether patient needs catheterization or not. Pleural effusion can affect cardiopulmonary status and therefore desaturation and other things. And diaphragmatic assessment is an integral part nowadays when we are talking about delayed extubation, we are talking about phrenic nerve palsies. So everyone is aware about the lung sliding sign, and when we put an M mode, it picks up the motion all across, and whenever there is a pneumothorax, you don't see that's the barcoding sign, because between the viscera and the parietal pleura there is good collection of air, and therefore instead of a seashore, we tend to see here is a shore. So instead of a seashore, we just see the barcode sign. Now pneumothorax, the pathognomonic sign is the lung point, and it can be very well easily picked up with the help of a lung ultrasound. So the patient must lie in supine position. There are many occasions where giving a sigh breath, giving a high tidal volume, sometimes the surgeon will say Valsalva, and there are chances of causing pneumothorax. Coming to B lines, this is a very good idea when we are talking about fluid assessment. It is not only IVC assessment, but looking at bladder and looking at lung, and it completes the drill. So if there is any waterlogging, we definitely see these vertical B lines. More the confluence, the more the pathological the lung is. Even in our pediatric age group patient nowadays, a newly born patient, and we are helping our pediatricians to decide whether it is a respiratory distress syndrome, and you can see these multiple B lines, and nowadays AI is into picture where it can pick up auto B lines and things like that. So even the surfactant titration can be done with the help of B lines. If patient has received good amount of surfactant, the B lines are converted to A lines, and it has been very useful. Plaques area is another area where when it comes to lung ultrasound, we must place the probe in the posterior axillary line. It is a highest yield area for pleural effusion, compression atelectasis, and you can pick up consolidation. Most commonly the pleural effusion and pneumothorax, and the surgeon is asking you for recruitment maneuvers at the end of surgery. So you might as well put the probe where we are looking at the base of lung, and whether the recruitment has been done or not, we can very well guarantee it. In pediatric patients, it is even easier, because in pediatric patients the skeletonization of the sternum has not happened, so the diaphragmatic movement can be picked up very well, and we can see the simultaneous movement of diaphragm, and you can see diaphragm going up and down. So endobronchial intubation in pediatric patients can be very well ruled out with this type of a single intervention. And lung thickness, the diaphragmatic thickness and the strength of diaphragm is again a new area which is picking up very heavily, and we need to calculate the fraction. If fraction is less than 20%, we may not extubate these patients, and we have excursion, and we have a M mode reading, and so it may not be possible to cover in a small presentation. Now coming to the basics of airway, it can be done in supine position, it can be done in sitting position, and today morning there was some discussion on airway as well. So at least if we are very sure about the anatomy, the cadaveric anatomy, where is the thyroid, where is the cricothyroid membrane, the yellow one is the cricothyroid membrane, the purple one is the signet ring, which we see as the cricoid cartilage, and below are the tracheal ring. So where is the cricothyroid membrane? Dr. Jiggy was mentioning that people will have very difficult time to do a cricothyroid puncture. Why not do it, mark it beforehand? And even some of the aggressive thinkers like Pankaj Kundra, he would say that we are putting an art line just in high risk patients and remove the art line at the end of surgery. Trachea is so big, why not put a 16 or an 18 gauge cannula prophylactically when we are really worried about the airway, and just remove it at the end of the drill. I have done it myself, It is little tricky to oxygenate through it. It gets filled with secretion, but if you hold it, some oxygenation will be there, and you will have additional few seconds for fiber optic intubation or whatever drill you are doing. So it can be of advantage, and at least you have some marking, or else you can just mark it beforehand and use it. So you need to correlate what all the structures are, and if you are very well aware that behind my Adam's apple, like here you can see behind the Adam's apple you have larynx, just below the Adam's apple you can have the cricothyroid membrane and the cricoid cartilage. Above the Adam's apple we have hyoid and epiglottis. So there are different airway criteria where we can predict what is a difficult airway. Now today morning there was another discussion in those high risk intubation. Sir was explaining about putting a video laryngoscope or prophylactic upfront use of bougie. Now there are ACC guidelines, ACLS guidelines to suggest that we can just park our probe in the curvilinear, in the transverse line, and like this, and we can just see the esophagus and we can see the trachea. So once the tube is passed in, whether it has gone, now here you can see that this is the esophagus, and here is the tracheal ring. So once the tube is being placed, I am very well sure whether it is going into trachea or whether it is going into esophagus. So now previously, 1 year back we were all worried about COVID. So nobody wants to give those 6 breaths and check with EtCO2, and then you have to confirm whether it has gone in or not. I remember when in my previous institution at Hinduja, and I was with Dr. Farad Kapadia, and I have intubated one patient in casualty, and he said there is no EtCO2, remove the tube. And I placed it one more time, he said no EtCO2, you remove it. Then another machine was called, again no EtCO2. Then I said, sir, it's really in, you please check it. Sometimes it is difficult to get on auscultation. Then we found out that EtCO2 machine was not functioning well. And it can happen with anyone, but I think ultrasound is, so I am also worried when junior is doing intubation for the first time, where he is going to put the tube. मेरे को दिखा तो कुछ दिख नहीं रहा है. So let's place the probe, and I am very well sure where the things are going, and I can check my tube very well in place. So you can't miss if it has gone in esophagus. So this is how you will see a very big tube in the esophagus, and you can pick it up very nicely. So you need to know where is the cricothyroid membrane, where is the thyroid cartilage, where is the cricoid cartilage, mark the line and mark it prophylactically. Now this was when we are talking about endobronchial intubation in long axis scan, we can see the end of the tube. We can inject saline in the balloon, the ET balloon, and we can check where the balloon is inflated. If it is going beyond 3rd and 4th tracheal ring, probably we are dealing with endobronchial intubation. So here itself we can help. Now vocal cord movement, anesthetists are always fond of knowing vocal cord movements, the arytenoids moving very well or not. It was a very miserable and barbaric experience when surgeon at the end of thyroid surgery is asking me, "Mujhe wo cords dikhao," and then the patient is shouting, bucking, what not they are doing, and nobody sees whether they are moving or not. But dikh rahe, it's like that. So we really want to know what is happening to the patient, and so I think this is a very good idea in which we can pick it up. Coming to gastric ultrasound now, gastric ultrasound is nowadays called as extension of airway assessment. It is the lower extension of upper airway assessment. So it is a lower airway assessment, and there were many occasions when surgeon will say, अरे वो सिर्फ मुझे ना DL-स्कोपी करना है, थोड़ा सा propofol दे दो 5 मिनट में हो जाएगा. So then I have started showing the gastric content to my surgeon, and sometimes I zoom it. So they see, oh, इतना उपमा खाया है, अभी तो नहीं. So something like that. I'll finish in 2 minutes. So these are the features, and nowadays ready-made charts are available. You can pick up the pyloric antrum and you can conclude it. Thank you. So there are limitations. There was point about credentializing and limited availability and resource. I think things are changing for good. Regional anesthesia I have not covered, but ultrasound and regional anesthesia are integrally connected. So thank you very much. Thank you for patiently listening.
One thing I realized now that sooner or later this age-old stethoscope will be replaced by ultrasound probe, and all anesthesiologists, as a cardiac anesthesiologist, neuro anesthesiologist, one more specialty will be there, that is sono anesthesiologist. And second thing is that now MUHS has also incorporated 15 days, I think 2 weeks rotation for a PG student in radiology department for sonography student. Thank you.
Thank you very much.
I request our chairpersons to felicitate our speakers, Dr. Amit Dixit and Dr. Gitanjali. I request Dr. Sai and Dr. Girish Saunandikar to kindly come up on stage and felicitate our chairpersons, Dr. Satish Padke and Dr. Abhinay Haran Khedkar.
Amit and me both are co-fellows at the law hospital.
She has been very wonderful because she's one of those very few anesthetists who has completed ADIT and recently cleared her EDRA Part 2 as well. Congratulations.
I request the chairpersons to felicitate Dr. Nupur Chowdhury. Excuse me, sir. I request the chairpersons to felicitate Dr. Nupur.
Moving on to our next session, coagulation. Coagulation and neuraxial blockade is always an evergreen topic for any anesthetist. I humbly request Dr. Sachin Arbi to come up on the dais and begin with our next session on coagulation.
Good afternoon, everybody, for the pre-lunch session. We will not take much time. And coagulation is a lot of gray area with lot of new drugs coming into the play with names which you can't even pronounce, let alone remember. The trade names are different, the active ingredient is different, and their half-lives and their. So to enlighten us about these drugs, I would call upon the chairperson first, Dr. Sameer Kulkarni. He is a intensivist at Kashibai Navle, and multifaceted again. He's co-authored a book and has major publications in national and international journals. I would introduce my colleague at Ruby Hall, Dr. Neeta D'Souza. There's a long list. I would not take time, but she is, I can say, again, a multifaceted one with EDRA to her name. She is having a lot of publications in national and international journals, and she is a ATLS and ACLS instructor. The other person, or the other colleague of mine or friend of mine is Dr. Sandeep Mutha. You know him very well. He has organized a lot of conferences in IACTA, EORA, and again a multifaceted personality. So I would call upon Dr. Neeta D'Souza to start the session.
Thank you very much, Sachin. It is an evergreen topic, and I agree there will be grey areas even after my presentation, which you all will have to read up through the guidelines. So, at the outset, a very good afternoon to the respected chairpersons, the coordinator, dear friends, colleagues. The topic definitely, I am sure, all of you all have encountered patients. all of you all have encountered patients who have been on anticoagulants. Let me tell you, there are ASTRA guidelines, ESRA guidelines, the recent European Journal Anesthesia guidelines, which are over 100 pages. So it is very difficult to make it very brief in over 15 minutes. And I have borrowed 5 minutes more from my next speaker. So let me see whether I'm able to do justice to this. I may skip a few slides, but this material is freely available as PDFs online. So let's just try to grasp as much of this topic. So in the overview, some brief about coagulation, what exactly is a thrombus, what do we follow till date, what are the current EGA to 2022 guidelines, which are the drugs being discussed, what are the tests that can be done to evaluate the coagulation profile, is there any algorithm that we follow. There are lots of charts and guides that we can actually save in our phones for a quick reference. But one thing that I often notice is even when we do pre-anesthetic checks or the residents tell us the patient is on this drug, no one cares to see what is the generic, which is very important because the generic is actually what we need to look at for looking at which class of drug it is, what is the half-life of that drug, and how does it impact our plan of anesthesia. And of course, certain complications, which again are very anecdotal and just got from case reports and case series. So why did the guidelines come into the picture is because there was a need for a consensus. There is no standard protocol, like if it's aspirin this dose, this should be done or that should be done. So there's a lot of confusion over it. And of course there is lack of evidence because we're just referring to expert opinions, case reports, case series, the pharmacology of that particular drug. So there's no hardcore, a lot of evidence-based material in this. And again, the time intervals, you need to refer to different pharmacological books to see what their half-life is and actually measure these drugs after giving a single dose, how much of this actually does exist in the body after maybe a day or two or after a few hours. And of course, the role of renal function as well. So coming to what exactly is a thrombus, both a venous and an arterial thrombus. A venous thrombus, there's a small part of platelet component but a large fibrin component. Whereas in arterial thrombus, it's primarily an underlying atherosclerosis with a large platelet component. Apart from knowing which anticoagulants are there, and the surgeon calls us and asks us that this patient is on fondaparinux, तो कितने दिन बंद करना है? So our role does not end at just telling that particular surgeon that हाँ 3 दिन 4 दिन बंद करो. We need to risk stratify that patient as well. And also an important role is to tell that surgeon that he is on this particular drug for this pathology. Please make sure you start it at this time. Which often I'm sure 80% of us do not go back and tell that particular surgeon. They start it at their own whims and fancies. Bleeding हुआ तो 24 घंटा बंद रखो. Bleeding नहीं हुआ तो 2 घंटे में चालू करो. Drain में कुछ है तो बंद करो. It's that. So that's really vague. So this, we know that the coagulation pathway, both the intrinsic and extrinsic, heparin acting mostly on the intrinsic as well as the common pathway, an age-old drug along with warfarin. Importantly, a lot of low molecular weight heparins and even newer ones are coming, which are even ultra short-acting ones. And again, concerns, I will discuss them in detail. I wouldn't spend much time on this because we'll come to the drugs. So talking about anticoagulants, oral anticoagulants, primarily the vitamin K antagonists like warfarin, commonly that I will discuss. With regards to directly acting, direct oral anticoagulants, Dr. Mukta will detail them, but the common names like say rivaroxaban, we don't hear that the patient is on rivaroxaban. We often hear that the patient is on Xarelto. So those trade names should be known to us, or maybe you can just keep one snapshot on your mobile for quick reference. So apixaban, endoxaban and dabigatran, which is commonly known as Pradaxa. Amongst the low molecular weight heparins, again, just saying that the patient is on low molecular weight heparin doesn't suffice. There is a low dose, there is a high dose. Whether that low molecular weight heparin is therapeutic or it's prophylactic, also we need to know because we need to stop it accordingly. Coming to unfractionated heparin, which is really short acting, which can be given both subcute as well as intravenous. And a whole class of antiplatelet drugs, starting with our age-old aspirin, some NSAIDs, which again we do not pay as much importance, but NSAIDs also need to be stopped in certain cases. Thenopyridine derivatives, clopid, prasugrel, ticagrelor, cangrelor, which is again a new drug with a very short onset and a rapid offset as well. The GP2B3A inhibitors like Riopro, which is abscessamab, integrelin, tirofiban, and the phosphodiesterase inhibitors. Again, a small mention I will mention on herbal, which is ginseng, ginkgo, as well as garlic. Now, why do you need to risk stratify? Since the topic is primarily on the neuraxis, I would say just to read up the highlight. Just to make note, it comes in pain guidelines. It comes under the neuraxial injections come under in the intermediate risk, whereas in the regional guidelines, the neuraxial blocks come under high risk. So this is very important to stratify whether the anticoagulants can be stopped. Definitely the time duration needs to be taken care of, especially when we're giving regional, considering the neuraxis. Now, spinal hematoma, again, very anecdotal reports, but this number is an age-old incidence that is being carried forward. With regards to epidurals, I don't know if you can see it at the back. With regards to epidurals, the incidence is 1 in 1,50,000, whereas in spinal anesthesia, the hematoma, the incidence is 1 in 2,20,000. Now, spinal hematoma for us, of course, is a complication that needs to be handled. Another very scary picture is that even patients who are not on anticoagulants have landed up with spinal hematoma. So it's not only that to note whether your patient is on anticoagulants, but also certain age groups which are predisposed, like an age group of more than 65, 70 years who are primarily hypertensive, who are bedridden, who have had stroke in the past. So these age groups, they might have been on certain drugs, medications, or there's something called as a CAD score, which may be high. And these patients can have spontaneous bleeds even if they are not on anything. So if they can bleed without anything, and we give a neuraxial block in such patients, so one needs to be aware of that as well. So with regards to spinal hematoma, just an important thing is identifying the symptoms as early as possible. That's some kind of neurodeficit, back pain, and diagnosing it as early as possible. That would be on an MRI. So if there is a doubt, there is an element of doubt, it's always advisable to get an MRI done. And of course, if required, a decompression, laminectomy as early as possible, depending upon the imaging, and then consult with the neurosurgeon. Again, as I told you, the worrisome is the data. This data is prior to all these anticoagulant drugs and newer drugs which is coming in. So we don't have recent data on the number because often complications are not reported. And definitely the recent epidemiology suggests that the risk is much more. Again, the same numbers, but over here to mention the neurological outcome in patients with spinal hematoma following a neuraxial blockade. The good part is the interval of onset of paraplegia and the surgery. If it's less than 8 hours, you'll see that 6 of them actually have recovered. And if it's gone beyond 24 hours, the recovery has been poor. And there was no surgical intervention required in a few. So this is to point out that early detection definitely is essential. Again, in this slide, noting these highlighted points, if there was no heparin in picture, still the estimated incidence of spinal hematomas is 1 in 3,20,000. But if it was a traumatic puncture, suppose you attempted and there was blood in the needle, and it would be considered as a traumatic puncture. So in that case, and patient is not on any heparin, the incidence comes to 1 in 30,000. Whereas heparin anticoagulation following neuraxial procedure. So the patient is on heparin for some reason after you have performed a neuraxial block. And it was traumatic, it's 1 in 1 lakh. But if it was traumatic, it goes as high as 1 in 3,000. and if this heparin is with aspirin. So we also need to be careful and watchful about combination drugs, right? So with aspirin and heparin, it goes to 1 in 12,000. So what exactly are we looking at with regards to when do we stop the drug? So important being the plasma half-life of the drug. So now the plasma half-life is when we consider, five and a half half-lives, we consider that the drug is very minimal in the circulation, or at the plasma levels are so minimal that you can consider that there is minimal blockade, or there is absolutely no anticoagulation at that level. It's only around 3% of the drug remains in the system, and the drug is practically entirely eliminated. So importantly, this was a study by Greenblatt in way back in 1985, which said that one half-life, 50% of the drug is in the plasma, 2 half-lives, 25% remains in the plasma, and with 5 half-lives, hardly 3% of the drug is in the plasma. Now, why this 2 is highlighted is certain European guidelines for superficial blocks even consider 2 half-lives as okay, because 25% of the drug is in the system, which is not as worse for superficial blocks, which is not the topic which we are discussing, so I won't go into details. Now again, there are lots of such charts in the presentation, but it's very difficult to discuss all of them. Just to emphasize and to tell you, amongst the antiplatelets, aspirin definitely is what we encounter on routine basis, knowing that the time to peak action is 1 to 2 hours, half-life of 15 to 20 minutes, and this is the usual. There's something called as a routine dose, a bolus dose, loading dose, which again you need to note, because a loading dose definitely is going to cause more blockade of the platelets. Then coming to a common drug, which is Clopid. So often you will see medications like Plavix, you will see combinations of Clopid with aspirin. The time to peak action is 45 minutes, half-life of 6 hours. So Clopid we routinely stop 5 to 7 days before any neuraxial procedure planned. Other drugs in the same class are Pasugrel, Ticagrelor. Again, Ticagrelor, the time to peak action is as short as 1.5 hours. So onset is really fast, and the half-life is 7 hours. Cangrelor is really quick, within 2 to 3 minutes. So we often in our cath labs, there are certain cardiologists who say that give Cangre. Of course, there are cost limitations. It's good for us because the offset is fast. But again, for the patient, thrombotic tendency of that stent rethrombosis also will be as fast. So happiness brings sorrow also. And of course, abscessimab. So I won't go into the deep pharmacokinetics and pharmacodynamics of these drugs in detail. We'll see it in some charts. Coming to aspirin, we know that it causes 60% of the platelet inhibition, and 10 to 15% of the circulating pool is daily supplemented back by the platelets. And after 4 to 5 days of stopping, 60% of the platelets are unaffected. So this is the reason why some people still stop it for 5 days, although there are more recommendations as that. So for regional and low risk procedures, we continue, but for medium and high risk procedures, we consider even for neuraxial blockade, we are not actually wanting the surgeons to stop aspirin. So if it's a primary prophylaxis, like the patient is just taking it because of age, they can easily stop it for 6 to 7 days. If it's secondary prophylaxis, they can stop it for 4 days. Cilostazol and dipyridamole, again, the mechanism is it decreases aggregation and causes vasodilatation. In regional, they continue, but with high-risk blocks, and even with aspirin, this combination called Agrinox. So the T half-life is 10 hours, so 5 half-lives will be 50 hours, so the drug needs to be stopped for 2 days. So it is definitely high risk for deep block and for neuraxial block, and should be stopped for 2 days. Now, just salient points over here for aspirin and NSAIDs. Short-acting NSAIDs such as ibuprofen, diclofenac, endomethacin, usually the action is normalized after 24 hours, and more than 50% is restored after 6 hours. So usually you don't stop them or have any restriction over them. Again, there's a little controversy about what is low-dose aspirin and what is high-dose aspirin. There's a little paradox, because if you consider NSAIDs, they have a normal platelet adherence to the subendothelium and normal primary hemostatic plug formation. So actually they don't need to be stopped right away unless it's a very high dose. And with regards to large doses of aspirin, like 1.5 to 2 grams per day, it will also inhibit the production of the prostacyclin, which is actually a potent vasodilator and a platelet aggregator inhibitor. So a large dose actually is more thrombogenic versus a low dose of aspirin, which is theoretically, it's a greater risk for bleeding. So low dose aspirin is the friendlier one, which causes more blood thinning or antiplatelet action. Now coming to warfarin, we know that warfarin, most of us have had patients who have had valve replacement or on deep vein thrombosis and need to be monitored with INR. So our traditional way as it goes, we keep warfarin off for 5 days. But if they have other comorbidities, it may take a little longer for that INR to come down to less than 1.5. So when there is an elevated INR, it can be reversed with vitamin K, oral or IV vitamin K. And if there is life-threatening bleeding, you can consider giving prothrombin complex concentrates, either with factor 3 or with 4 factors, that is including the clotting factors. So that's why it's called 3 and 4. So 4 is more beneficial versus 3. And it is better than giving recombinant activated factor 7A because it has its own complications. Now again, as I said, with regards to sensitivity associated with increased sensitivity to warfarin, you need to be very careful if the age is more than 65, females, or if the weight is really less than 50 kgs, any liver, coexisting cardiac or renal disease, Asian ancestry. Again, I think some guidelines need to come from India, like how airway has come in, resuscitation guidelines have come in, with regards to how do we have too much of difference or what is our incidence with versus, always following European or American guidelines. Because certain new drugs have not yet come to India, but we are studying them because they are reported in the guidelines. And excessive surgical blood loss. So again, a patient, perioperative management on patient with warfarin, mentioning that if it's pre-op and I plan to do neuraxial blockade, definitely I'm going to keep a check on the INR. If the INR is less than 1.5, 1.4 is a good way. But of course, if it is for venous thrombosis, whether the patient can be shifted on any other bridging therapy, I think we as anesthetists should also behave like a little perioperative physicians and take active part in that patient's management. Because the patient is at risk when you're stopping everything. It's not just that your spinal has to work and patient, like your job is done. So I think an active participation with regards to what is the bridging therapy for this patient and when am I to resume the medication as early, right? So just to mention, post-operative, the patients who are at low risk of thromboembolism, you resume warfarin on the post-operative day. If it's high risk of thromboembolism, who have received or depending upon the surgical procedure. If it is minor, you can resume within 24 hours, resume therapeutic low molecular weight heparin within 24 hours. And if it's a major surgical procedure, you can wait for 48 to 72 hours. So it's not that I'm starting back with warfarin because again, it's going to be longer acting. So that bridging therapy. So I think we need to actively take part in that as well in planning. Now coming to INR. Now have everybody with regards to not only with warfarin, but an INR of 1.5. How many of you all have gone ahead and given a spinal? That's because we've heard that 1.5 is okay. Anything beyond, if it's 1.54, what do you do? 27 number needle. So, but 29, sorry sir. I don't use 29 very often, so I'm scared that it may fail. Or it may be partial action. So, coming to this, just to bring to your point, in chronically anticoagulated patients, definitely it is of concern. But as such, even if the patient is a little bit in sepsis and the INR comes 1.6, do FFP, they do spinal de denge. So it may not be that simple. Why I will mention is that INR, it's more sensitive to the clotting factors 7 and 10. And it's prolonged when the factor is reduced to approximately 55% of baseline. So if its INR is 1.5, is associated with a factor 7 activity of 40%. We need clotting factor activity of more than 40 to 50% for normal coagulation to work. Okay. So if INR is less than 1.5, it is associated with normal coagulation. So that was the reason why the same guideline should apply for removal of the epidural as well. Because some surgeons, despite epidural being there, there's no coordination between the surgeon and the anesthetist, and they go ahead and say LMWH chalu kar do. They don't know whether epidural is there or not there. So in case that happens, either we check for the LMWH hours after catheter placement and then timely remove it, or we definitely need to look at INR also. Considering what I've written there as ASTRA is 1.2 INR and ESRA is 1.5 INR, ASTRA is more conservative with regards to INRs. So they take 1.2 as their cutoff. The reason being they have very obese patients with very high dosage and they've seen too many hematomas is what they say. But ESRA is a little okay because they say that, I'll come to those points. So ESRA takes it as 1.5. Now these again, there are going to be many charts like these which I may have to skip because of paucity of time. Again, just to mention NSAIDs in this, we consider 5 half-lives. So this is all mentioning high-risk procedures. So I'm just going to check this column. Diclofenac 1 day is okay, but this as such, it's okay not to stop unless it's this, I don't know how many of us use piroxicam for long duration or naproxen for a very long duration. So few of these, I'm just going to discuss the salient points. So coming to low molecular weight heparin, if it's prophylactic, again prophylactic can be considered as once a day dosing. With regards to heparin, first let me cover heparin. With regards to heparin, there can be subcut as well as IV heparin. So one needs to see the total dosage that is going in the particular day. If the dosage is more than 10,000 units, then definitely you need to stop it for 24 hours, a longer duration, not for subcut and IV, for 6 to 8 hours. But if it is less than 10,000 units, then you can just wait for 4 to 6 hours. If it is subcut or IV, in the sense unfractionated heparin. Coming to low molecular weight heparin, which is prophylactic, you can high-risk procedures, we stop at 12 hours, and intermediate, I'm just going to consider high risk now, and you restart it within 4 hours after low risk procedures, or if they're high risk, 12 to 24 hours later. But when it's therapeutic, when I mean therapeutic, it's a higher dose of low molecular weight plus it is a BD dose. Now in the West, in America, there's a trend of surgeons using for the last 3-4 years TDS dose of heparin, and they are not ready to let go. So those patients, definitely you cannot start anticoagulation, or you can't start prophylaxis immediately, but you need to restart it only after 24 hours. And we stop also, if I'm planning a spinal anesthesia and an epidural anesthesia, I need to stop it for 24 hours prior. Again, salient, I don't know whether people at the back can see, I'm just talking about the yellow ones, which is antidepressants, and that is serotonin reuptake inhibitors, also have a major role and may need to be stopped for a longer, definitely add to the anticoagulation, but it's better to have a change of plan if necessary, because we don't want a depressed and a anxious patient coming to the OT. So it's not that without spinal kaam nahi chalega. We can look for other options in select patients. This is the main guideline which came way back, 4th edition, which came in 2018. And again, the first and the second consensus did not have much mention on obstetric population. So they thought something needs to come about obstetrics as well. And they focused only on neuraxial blocks and anticoagulants in surgical patients. The third consensus based limited information that parturients or obstetric patients are similar to non-pregnant patients who are undergoing neuraxial block. And they did introduce newer oral anticoagulants which was approved by FDA. And FDA has their own guideline. So Americans are a little more conservative, but if FDA says 4 hours is enough, they also go with 4 hours is enough. Although according to half-life, 6 hours should be waited for certain drugs. So as I said, lower levels of anticoagulation are associated with prophylaxis. Only 2 half-life interval is required. So FDA has recommended a 4-hour time interval between catheter removal and subsequent low molecular weight administration. So few newer recommendations did come.
2 minutes.
Left, okay. 5 minutes of service. So that's what I'll skip a few slides. The common ones I will not mention. Unfractionated heparin. This I think we can. This is all from the text. Just the salient points I'll mention. With regards to heparin, the recommendations being subcutaneous dose of 5,000 unfractionated heparin, 4 to 6 hours delay after administration for needle placement. This I have discussed, but this is available. I'll just come to certain fondaparinux or Elixtra. Its half-life being 17 to 21 hours half-life. In regional guidelines, actually there is no recommendation. But again, if suppose this drug is given, the surgeon wants to give fondaparinux, it suddenly became a very hot favorite of many intensivists. So then we also need to interact and tell them that if you want to give it, let's remove the epidural and give it after 2 hours. So in the pain guidelines, again ASRA introduced the 4th edition for mentioning their pain physician aspect as in deep blocks or facet blocks. So that again has clear-cut mention in the 4th ASRA edition. I'll skip a few if I have only 2 minutes. Okay, so coming to dabigatran, rivaroxaban, Mutha sir will elaborate on this. But just to mention, we need to know the generics, as I said, just not ki dabigatran, Predexa. But what exactly, how long does it, or rivaroxaban, Xarelto. So the regional guideline says it also the renal function matters. So calculating the GFR to see whether the creatinine clearance is good enough to stop it just for 3 days or 4 days depending upon reduced creatinine clearance. Okay? And the pain guideline says that they should practically, the entire newer drug should be stopped for 3 to 4 days. Now these are a battery of tests that can be done. I'm not going to be discussing all of these tests, but this is what, now it's not easy for factor 10A inhibitors to sit and do the factor 10A assay. The easier way to do is probably to see the CHAD score, to see whether this patient is really high risk, and to see whether the half-life of that drug is definitely cleared, to be on the safer side. Okay. Now the newer tests such as, so these are the different laboratory monitoring. I tried to find out whether this ECT, which is very specific and very sensitive for dabigatran, is available. I couldn't find it out whether Eccrine clotting time is there. And these are expensive tests, which are 3,000. It's not about only the expense, but yeah, Indian scenario, expense also matters. But they're not very easily accessible, except for our PT-INR platelet, TEG is there, and BTCT. Okay, so these all tests definitely are there. Coming to this TEG, now what happens is many people say, "Haan, Clopid 2 din se band hai, we will do one TEG," and if the TEG is okay, we will take the patient. Please note that a TEG is a in vitro test which is done. You cannot just equate it directly with an in vivo cascade which is going on. So it's a complex process. Blood coagulation is a complex process, and there is interaction between the tissue factor, endothelium. How can we replicate this in vitro? It's difficult. Blood flow, vessel size, local vessel biology. So it cannot be quantified in vitro always. So the main principle TEG measures is the blood coagulation in vitro. So I would say it's a poor predictor of platelet adhesion and von Willebrand disease related to bleeding diastasis. So again, such charts I would suggest kindly keep it on your mobiles for quick references. These are the guidelines which I have referred to. It's easily available online if you just type in EJA regional guidelines for 2022. It's the same, there's a chart. 2-3 important things, whether there is last 1 minute. Summarize. Role of USG, again there's no much role of USG because for neuraxis you know where the depth to the dura is, but we are not worried about so much of vascular structures there. It does not have any influence on the time interval is what the EJA guidelines have said. Again, few differences between ASTRA and ESTRA. I said ESTRA is more liberal, whereas ASTRA is more conservative with regards to INR, renal function. This is again one important thing with regards to pregnant patients. Inherently, pregnant patients are more it's a thrombotic state. So all these cases are where pregnant patients were hardly given any, there was no coagulopathy or anti-coagulants going on, and still they landed up with spinal hematoma, maybe because of additional HELP syndrome or pre-eclamptic status or thrombocytopenia. So in obstetric population, we need to be a little more cautious whether because of infertility treatments are there or any other anticoagulants. So what I would say is unplanned anticoagulation with neuraxial catheters. Suppose there is a catheter in C2 and the surgeons have started something. So you need to have a multidisciplinary approach, document it, inform the APS team, and discuss with the surgeons before this actually happens. Removal is advisable if you can coordinate and tell them before you start, let us get our catheter out, and close monitoring of the neurological status. So this I'm going to skip. This is the chat scoring which I mentioned. Just to highlight, if the chat score is 2, the stroke rate increases by 4%. And if it's 3, it increases by 6. So this is the importance of starting the anticoagulation again, after it is stopped for our neuraxial blockade. Reversal agents will mention, Mutha sir will mention. Novel anticoagulants I'm skipping. Herbal medications with regards to garlic, ginkgo and ginseng. If the patient is taking more than 2000 milligrams per day of garlic, then it's others will know as well. So it needs to be stopped for 7 days. So, but I have not encountered, the seniors can tell me if they have seen patients with, of course, a lot of new drugs, so we are definitely having more guidelines coming in the coming years as well. So, few similarities and differences, I'm ready to share slides if anybody wants. Checklist, this is one important, I just spent maybe 30 seconds. History should be noted because do they have any bleeding tendencies? What are the coagulation tests? We have to review whether the patient is for primary prophylaxis or secondary prophylaxis. See which area you're going to actually block. Is there any radiological imaging? And one needs to do a pre and a post procedure surveillance, which is very important, which needs to be documented. How many of us document the patient's legs are moving after spinal anesthesia has worn off? हमारी recovery में sister knows umbilicus के नीचे sensation गया तो shift कर दो patient. Okay, but actual movement of the legs, so neurological monitoring, documentation, again I would emphasize reconfirm medication, verify generics and check for other drugs affecting clotting functions and 2 drugs as combinations. So when in doubt, refer guidelines, stay safe, risk stratify. Thank you.
Thank you, Nita. We'll take questions after the second lecture. It was quite exhaustive to put so much of information in just 15 minutes. Yeah. Okay, Nita, Keka madam wants to ask you. Dr. Mutha, you have 2 minutes.
I'm not going to take 10 minutes for my question. She
Dr. Mutha.
talked about INR in case of LMWH. If the surgeon has given INR doesn't correlate. No, but you had shown in the slide INR. So yeah, for LMWH there is no test except factor 10 assay. And second I want to say something. Yeah, no, it is INR. I have seen it.
No, but INR is prolonged with LMWH also. So it is prolonged. It is prolonged. But if you do it, you find it prolonged.
The most important thing is 2 half-lives. Before removal of the catheter, that is the time duration is the most important aspect. I wanted to add something more.
When so finishes, you can.
No, but if INR is even in low molecular heparin, you cannot go blindly just because we don't do
because surgeon has given, you just have to rely on the timing. That is the most important thing.
2 half-lives I agree for removal of the catheter. There is nothing to measure LMWH except for factor 10 assay. INR is specifically for warfarin. But there are certain patients without giving anything, the INR is like early sepsis. So for them, you will have to do an INR to see they are not gone beyond and you have an epidural and they have gone into sepsis.
Secondly, I wanted to say something more important, that about the post-op, that is a very correct, that post-operatively we have to note when the motor action is coming back. But here the additives of local anesthetic, additives to local anesthetic, because usually they have a very prolonged action and then you are really worried whether the recovery is not there because of your spinal hematoma or
So
because of this.
it's advisable to use short-acting
Yeah,
agents
and
so that
not
it
to
wears off.
add anything for the post-operative
Specifically with
anesthesia.
clonidine.
Yeah,
The legs are not moving for 6 to 8 hours, I have noticed.
Even out of narcotics, I would say only fentanyl would be
More than
safer.
that.
No other additive which will give a very prolonged block. Because the duration, the 8 hours window period is very small, and even in that there is 50% loss.
Sir, Mutasar. Sir, you can start, please.
Thank you, Anita, for covering most of the things. I'll try to be shorter and shortest. I'll be dealing with the newer anticoagulants. I'm Sandeep, these are my two companies. Mediparo, which manufactures the equipment, and this is my anesthesia company. So, basic introduction is antiplatelet, anticoagulants, thrombolytics, change of challenge to the anesthesiologist and the risk versus benefit. So we have to deal with bleeding and thromboembolic phenomena and all these things continuously. If the patients are on anticoagulants, they are old patients, thrombotic, something. Basically, you should know what is anticoagulant and antiplatelet. Anticoagulants are which prevent blood to clot, and antiplatelets are which prevent the action of platelet or clogging of platelets. So this Nita has mentioned, so I am not going to go into it. This is the development history of anticoagulants. We started with 1930, heparin, warfarin, nomenclature heparin, then the diethrombin inhibitors, factor Xa inhibitors, and then came the newer anticoagulants which were DTI, factor Xa inhibitors, that is dabigatran, rivaroxaban, apixaban, etc. So what is the ideal anticoagulant? Ideal anticoagulant is should be effective, that means it has to have anticoagulant property. It has to be easily administered, so oral is the easiest administration, good bioavailability, it should be monitored, predictable effect, less dependent on renal and the hepatic function, it should be reversible, short onset and offset, and less expensive. So these are the newer ones, the direct acting oral anticoagulants, also known as a newer oral anticoagulants. First of it is which inhibits the factor 2A, that is dabigatran, or which inhibits the factor 10A, which is rivaroxaban, apixaban, endoxaban, and betriaxaban. So they are basically recommended for venous thromboembolism, pulmonary embolism, and non-valvular AF. It is not for the valvular AF till present. Still, the studies are going on. The emergency reversal agents are available for these. So this is what Nita had told about the intrinsic system and the extrinsic system. So this is 10A where the 10A inhibitor is going to act, and this is 2A where the 2A inhibitors are going to act. So direct inhibitors of thrombin, that is dabigatran, which acts on the 2A. So it reversibly blocks the catalytic site of thrombin and prevents the conversion of fibrinogen to fibrin. It blocks the activation of factor 5, 7, 9, 11 and platelet aggregation also. So other tests can be done to monitor that. The onset is around half an hour to 2 hours. The T half is around 12 hours. Duration is 24 hours. Low liver metabolism, most of it is excreted by kidney, renal clearance of around 80%, 20% by the liver, and there is a reversible agent which is hydroximab, very difficult to pronounce most of these words. So 10A inhibitors, that is rivaroxaban, apixaban, endoxaban and betriaxaban, it inhibits the conversion of prothrombin to thrombin and thus prevents the fibrin formation and inactivates platelets. You can do PT, HPTT, but they are not very specific for that. The metabolism is by the enzyme. The viability of these drugs is very high. The linear cadence of endoxaban is around 50%, rivaroxaban 35%, apixaban 27%, and you can do prothrombin time for this. The mechanism of action of 2A inhibitors is inhibits the coagulation by direct binding to the thrombin and prevent the formation of fibrin. It also blocks these fibers which I told earlier. The factor 10A inhibits the trypsin like serine protease that plays a critical role in blood coagulation and binds to factor 10A and prevents them from cleaving prothrombin to thrombin. The different tests which can be done to monitor these, no tests are required as far as possible because the predictability of these drugs is very good. You don't have to change like warfarin, sometimes 1.5 milligram, sometimes 2 milligram, 2.5 milligram, and adjust according to INR. In these drugs, you don't have to do that. But in case of bleeding, there are multiple tests which can be done, but they are all non-specific. There are chromatogenic assays which are quantitative, or liquid chromatography, mass spectrometry, which also can be done, or you can do the level of the drug. The level of the drug can be around 30 micron per ml or 50 micron per ml. Less than that, it is less effective. More than that, it is effective. So, preoperative management of these drugs, because it has a faster onset and offset, and a good amount of renal clearance, there is little risk of bleeding. But multiple studies have shown in risk population like pregnancy or elderly people that the risk of bleeding is higher than the older drugs. You can stop it for 12 hours. No bridging therapy is required for this. You can restart around 6 to 8 hours later on. Bleeding risk, if the chances of bleeding is very high or if the drains are there, then you can wait for 72 hours before starting. And there is an emergency antidote available. The antidote for dabigatran is etrasimab, which binds to dabigatran and the metabolites both. Because metabolites are also slightly active and there is a renal elimination of this. You have to give around 2.5 milligram bolus and then an infusion of it and then monitor the bleeding. The factor 10A inhibitor, the antidote is andexanet. You can pronounce it as AN, dexa, that is dexamethasone, and net. So it will become more easier to know which drug. Alpha, it has a low dose regime. That means if the blood levels are less than 30 micron per ml, then you can go for 400 milligram bolus and 4 milligram per minute infusion. If the chances of bleeding is more and the levels are more than 30 or approximately 50, you can go for a high dose, that is not 8. Oh, sorry. It is 800 milligram bolus and 8 milligram per minute infusion. It is not 88. Sorry for this mistake. There is a newer drug which is coming up, which is known as PER-977, which is under trial, and this is supposed to be a universal antidote for all the oral anticoagulants. So now emergency reversal, you can use PCC, that is prothrombin complex concentrate, or the antidotes. PCC can be used for all the oral anticoagulants. Etrasimab has to be used for dabigatran. For andexanet alpha, you have to use for rivaroxaban, apaxaban, you can use andexanet alpha. And this new drug which is coming up can also be used for all the oral anticoagulants. Dosages are given here, and these dosages also will be changing with the change in the renal profile. So some of the studies like direct oral anticoagulants from randomized clinical trial to a real world clinical scenario, they said that direct oral anticoagulants are more manageable alternative than vitamin K antagonists to prevent the stroke patients, non-valvular arterial fibrillation, and to treat venous thromboembolism. They have not mentioned about the cardiac diseases or valvular diseases. Perioperative procedures and bleeding treatment again will be there. The special population, you have to be more careful. It can be used for non-valvular AF and the same thing which is there. So, coronary artery disease. There are some studies by Vahuket et al. Which said that it can be used, or it is under trial, to be used in the cases like acute coronary syndrome, percutaneous intervention, that is PCI, or existing valvular AF. But this is still under trial. With the mechanical heart valves, it is not recommended till now. Again, this is under trial. The limited evidence from a subgroup analysis of RCTs and cohort studies seem to preclude the use of these drugs in atrial fibrillation with the bioprosthetic valves. In a peripheral vascular disease, there was a last trial of 6,564 patient, that is a Voyager PAT trial, which 1:1 ratio, rivaroxaban 2.5 milligram twice a day with aspirin, and second group was placebo with aspirin. They said that 15% reduction in the composite outcome of incidence, but there was no significant difference in the safety outcome. So it was a very confusing report from this trial. In pregnancy, not recommended. There are some studies which said that dabigatran and rivaroxaban and endoxifen also can cross the placental barrier, and there is some effect on embryogenesis. So embryopathy is possible with these drugs, but this is still under consideration. Hepatic and renal impairment, there is increased risk of thrombotic events and bleeding complication. Dabigatran is the most renally eliminated, followed by the rest of the drugs. So in a renally impaired patient, the dose of these drugs have to be reduced. In 2018 European guidelines, they recommended the adjustment of apixaban according to the creatinine clearance. So in a severe kidney disease, chronic kidney disease, you have to avoid most of the oral anticoagulants if the creatinine clearance is less than 30 ml per minute. And in patients with a severe hepatic disease, based on the Child-Fuchs criteria which Neeta has mentioned, of grade C, all oral anticoagulants, these newer anticoagulants have to be are contraindicated. Now coming to the elderly patient, there is again increased incidence of bleeding, which I told earlier. In the meta-analysis, acute venous thromboembolism and stroke prevention.
2 minutes.
Okay. Higher doses can lead to more chances of bleeding, and this was again a last study of 272 patients with the age of more than 85 years, where they used these oral anticoagulants and had a higher rate of bleeding. Neuraxial anesthesia. Neuraxial anesthesia such as intrathecal or epidural anesthesia is used as a high risk for intervention, and if the patients are on these drugs, you have to discontinue. You have to discontinue for interval of 5 years according to 2018 ASA guidelines. According to the European guidelines, 2.5 interval time, that is 48 hours. So now you have to judge according to the bleeding profile, according to the patient profile, what you have to use, ATA guidelines or the European guidelines, or you can go for the maximum, that is 5 half-life. Estimated drug concentration remaining in the system should be less than 3.1%, and you have to check the levels. This is a big chart. I'm not going to go into details of this. How to use it for venous thromboembolism, stroke prevention, acute treatment of venous thromboembolism, then extended doses and the recovery. There is a mention of, it is very low down, so there is a mention on acute coronary syndrome, a low dose of rivaroxaban 2.5 milligram twice a day has been used. So you have to, in a low risk patient, you have to stop most of these drugs for 24 hours. For high risk, 48 hours. Restart most of the drugs by 24 hours if the renal clearance is good. For regional anesthesia, you have to stop for 5 days, rivaroxaban 3 days, dabigatran you have to stop for 5 days, apixaban and rivaroxaban you have to stop for 3 days. And you can restart after regional anesthesia by around 6 hours. I made the chart very simple to remember. Now recommended for major and minor surgery, which was summarized in the previous table. So the advantages are rapid onset and offset, predictable recovery, action and recovery, no bridging therapy, no need of coagulation testing, fixed daily doses, no dietary restriction, wide and therapeutic window, low bleeding risk, minimal drug interaction, and a reversible agent which is available. Knowledge of pharmacokinetics and pharmacodynamics will allow the practitioners to anticipate the difficulties and expected complications. In case of anticipated risk of bleeding, like epidural hematoma or something, better to avoid this. Rapid diagnosis and intervention is the crux of all the management for all the complications. You should be safe with your knowledge. So be vigilant, anesthesiologist, and have a high index of suspicion and rapid action to be taken in case of emergencies. Dhanyawad.
Thank you, Murtha sir. Thank you, Nita. Very exhaustive session. But I want to just conclude the session by saying that.
Two important comments to be made. There must, because I was just talking about. I had a patient on Friday, transferred from other hospital. IC bleed, and we were looking into what caused this problem, and their LFT normal, everything, nothing pertaining to coagulation. And later on, in the record we found that the inoxaparin was going on was 0.6 BD. There was no pathology to substantiate that why it was going on. And after a lot of time, we found that what is the cause of spontaneous bleed. And the only record came on this was INR was 4. We tried to find out, figure out what is the cause of INR 4. Later on, about an hour later, the whole detailed record we checked, we found that this was the only culprit. So common description is that INR doesn't get affected. Probably may be wrong, we do not know. And you can all have INR done in these patients just to find out what if you are in doubt. Second, regarding 21 Astra guidelines, do not allow to start newer anticoagulants if epidural catheter is in place. This is 2020.
Sir, I think according, sir, the INR being 4 and patient is on LMWH, maybe the patient may be having a CKD or left is deranged, so that may be the issue.
Everything was normal. We checked.
Can you have this?
Two quick comments. So one is, if there is gross overdose, your INR will be affected, but at usual therapeutic doses, your INR may be normal. So a normal INR doesn't exclude a therapeutic effect of low molecular weight weapons. But they could. The third thing is, the last thing actually, the very nice Astra app. So if you download the Astra app, it gives you all the guidelines depending on the situation. Like what is your drug is your patient on, what procedure you want to do, when should you hold, when should you restart. 2 lectures.
I got that on my mobile. I sent it to all the surgeons and
That's it.
orthopedicians.
Download the Astra app.
That's the concluding statement.
Okay, like Nita had told, this is garlic, that is Himalayan garlic, this is ginkgo, and this is ginseng, which are used and they cause a lot of problems.
Dr. Yogen Bhatt is not sitting in the crowd. Just now outside we were having discussion as he described the case with INR 4. He described one case. The patient had come with ectopic and INR was 17. And they were wondering why it is so high. So proper history taking importance is stressed in that. They went back in the detailed history and they found that the patient was consuming 3 different drugs, market names of the same drug, and that's why different doctors had started it without looking at the history. So it is most important to take a proper history.
The surgical bleeding?
No, but the patient, pre-operatively the patient was checked. And that time it was found that INR is 17, and then he went through the whole thing. Of course, he never gave a regional, but then surgeon of course was worried because it was an ectopic. And it was not an ectopic, it was a ruptured follicle. Because of the gross derangement of INR, the patient had bled profusely. So that...
I wanted to ask that intra-op, is there any extra bleeding and what precautions?
Intra-op,
Let's
this
discuss
was
this
before
over lunch.
the...
Let's discuss over lunch. Let's conclude this session.
I request the chairpersons to kindly felicitate our speakers, Dr. Nita D'Souza and Dr. Sandeep Mehta. Dr. Kalpana Kelkar ma'am to kindly come up on stage and felicitate our chairpersons, Dr. Sachin Arvi and Dr. Samir Kulkarni.
next time coagulation will be the last topic. And maybe the regional. I'm just pitching in just to announce the lucky draw winner from Neon, Dr. Satish Fadke, Dr. Rajendra Hardre, and Dr. Sarita Swami. Please collect your... Yeah, there is another draw going on. Please go.
We now move on to our next session. While saving and planned expenditure is the key in pursuit of financial goals, making smart investment with your money makes them much more attainable. The first step to successful investing is to figure out your goals and risk tolerance, either on your own or with the help of an expert. I now request Dr. Sushma Tanre to join me on stage and take over the next session on lessons in wealth management.
Good afternoon, everyone. Let's start with our session on lesson on wealth management by doctor for doctors. I invite Dr. Yogesh Gowri, professor in anesthesiology, currently affiliated with Government Medical College, Baramati, and Dr. Amol Ramekar, the consultant anesthesiologist at Ruby Hall Clinic, to chair the session. I request both of them to proceed with the session.
Good afternoon, everybody. So we are turning towards a different topic. So we are basically going to the economic part of it. Okay. I think everybody has read that rich dad and poor dad book. So after this, we'll come to the conclusion of rich anesthetist and a poor anesthetist. So I think Kedar will guide us, and he's a friend of mine. We have been together in BJ Medical College, and I think he requires no introduction. He is well versed with everything, WealthCon, the finance, then the market, equity, debt, everything. So he'll enlighten us with all the financial aspect of it. So I'll just request Kedar to please start.
First of all, thank you very much for inviting me. It's not a very common occasion for me to be on a non-gynac platforms maybe, but yeah, I'll take this as an opportunity to talk about a little bit about finance and wealth management. I have been a part of an organization which is called as WealthCon, which is a kind of a non-profit making organization for doctors, run by doctors of course, and I'll be speaking on that behalf. So I'm basically a gynecologist, laparoscopic surgeon and IVF consultant, but I'm also a part of WealthCon. Of course, as we keep on giving this disclaimer all the time that we do not provide any kind of tips or any kind of advices, but we are basically an educative platform. So we deal with educating doctors. We have around 50,000 plus doctors all around India and the globe who are associated with WealthCon, and we run different kind of courses and teaching for these doctors to be financially independent. Now let's come to certain myths we have. Commonly we have certain myths like money is not important, and of course there are famous quotes like money is not important, but I think this is good to say when you have a load of money with you. So it is important because though it cannot buy everything, but a lot of things which you need is eventually going to be bought with money. Wealthy people are bad, but I don't think that's really true. People are good and bad, and they may not be wealthy or maybe rich or not rich or poor or whatever. The other most common myth is share market is gambling, but that's not really true. Doing a share market business is like any other business, and people can gamble. People gamble in any other business and any other places in life, and so as in share market. Finance is difficult. I don't think it is really, because we are all postgraduate doctors. We have been through a rigorous course of MBBS, and in medicine and maybe in post-graduation courses, and I think any other course is not really going to be as difficult as it is. And we need a lot of time to track investments, which is again not really true. We may not need more than half an hour in a month to track our investments. So it doesn't kill your time. Of course, during learning phase, it may take a little longer time, but not otherwise. And what can be the proper age to enter? I think any age is proper to enter. We have a course which is going on, and currently I have a kind of a student with me in my small group of around 10 students, and his age is 73. He's an anesthetist, and he's almost kind of retired from his active work, but he has entered doing trading at this point of time. So any age is proper, earlier the better, of course. Now what are we trying to talk about? We are trying to talk about certain goals, and this goal is wealth creation. So the simple goal what we are trying to talk about is wealth creation. When we talk about wealth creation, there are three simple aspects. One is asset creation, protection with insurance, and tax saving. These are the three simple things. Asset creation, first step is save. We have to save money. Whatever we earn, we have to save that. Then we have to invest. Saving is not important, because if we save and then don't invest in proper channel, probably we are not going to get return. So saving is important, as well as investment is important, and for what time horizon we are doing so, because that is also important. We are going to come to every step quickly. Now I'll run through some points quickly because we don't want to waste much time. Everybody need to have a life insurance or a term life insurance, what we call, and that's absolutely a must. And that should be around 20 times our annual income, because that should protect us, our family, if in case of any untimely, unfortunate death of somebody. So that is very, very important. But most of the doctors get trapped in something called as ignorance policies, or what we talk about, the policies which combine investment and insurance. So most of the times all agents which come to us, and they talk about the policies which combine these two, and that is something which is really, really bad and not profit making, because in the longer run they give us hardly 4% returns, and they give a very, very minuscule life cover. So that's something which is really not good. Other insurances, as we say, are absolutely important. I'm not going in details of that. We have to understand the difference between being wealthy and being rich. So the simple difference is, maybe a wealthy person can earn lesser than a rich person, but his expenditures are less than the rich person is. So rich person is somebody who shows off with his expenditure. His richness has been seen. The wealthy person's wealth is not seen. So of course we need to understand that the true wealth is health, freedom, and relationships. So when we talk about relationships, it is always, if we have time, then we can dedicate to developing relationships. And freedom is again related to time. If we get more time, we can dedicate to health and relationships. And only thing which can buy time is maybe if we have adequate wealth. If we are creating some kind of a passive income along with our active income, because we are all professionals, we are working throughout the day, and we have a primary income. But if certain passive income comes along, I think that gives us a lot of freedom in our life. And a simple thing what we can just try and understand is, if we understand this simple concept, I think it helps us in great way in the longer run. So what is an asset? So whenever we spend something, of course we buy something. Let's see that if you buy a hen, I think that hen gives us an egg every day. So that is an asset. So that asset is giving us something which is repaying us back. But if we think something which is taking away money from our pocket, like if you buy a dog, I'm not saying that it's not good, but then if you buy a dog, of course it's not going to pay us anything every day. So if we say that, is this an asset, then the answer is no. This is a very simple example for to understand that what is an asset. So where are we putting our money in? So we may spending is different, but creating an asset is absolutely the other way. So we have to understand that what are the true assets, and true assets are something which are easy to sell. There are no emotional attachments or involvements which are connected with that. And the examples can be actually real hard cash, the fixed deposits, mutual fund shares, land plots, commercial buildings, gold, etc. Pseudo assets are which are difficult to sell. We have some emotions attached to them, and the examples can be the own house where we live. So suppose if I am living in a house which is worth 4 crores, I consider that as an asset. But is it really an asset? Then in true sense it is not. Because if I need 2 lakh rupees tomorrow, that house is not going to give me even 1 rupee, even if it is worth 4 crores. And that's why it's not a true asset. Doesn't mean that we not buy houses and all, but then the difference we need to understand. Again, a car if I'm driving which is worth 50 lakhs is not going to give me any income generation over a period of time. It is going to depreciate in value. Now, that is something which we have to understand the common concept as asset and liability. So are we creating more liabilities or are we creating more assets is something which we need to think about. Now real assets is something which appreciates its value over time. It gives us some kind of a recurring income, it gives less recurring expenses, and it has got good liquidity. Now the goals which we need to have are basic 3 goals. The first goal has to be the annual passive income we get through all these assets has to be more than our annual expenses. So suppose if I require 50,000 rupees to run my house, then I need to have a passive income of 50,000 rupees per month so that it takes care of my basic needs as my annual expenses. The second goal has to be the annual asset or the passive income which I get has to be more than my total income. So suppose if I am earning 2 lakh rupees, then my passive income should generate more than 2 lakh rupees a month. That should be the next goal. And the third goal is if I stop earning today, then I need to keep on getting at least the same amount as my annual income for the next 20 years. And this is something which is a final goal and a final goal of financial freedom. Of course, it may take time, it will take a lot of efforts, but that is something a real goal is. This is a common equation what we use in understanding the returns, and that is W is equal to P into bracket 1 plus R raised to N. So here all factors are important. It is a final wealth which we are talking about, but capital, percentage returns and time, everything, all 3 factors are important. If we save more, of course we can put more capital, because more we save, more we put into investments. Generating higher percentage returns is something which is a little tricky because that will need some knowledge and some kind of understanding about the investment products. But time is something which is easy. Earlier we start, more we stay in the game, obviously we can create more wealth. As we say, we generally go in this race that we work hard, we earn money, we pay bills, we spend more, we lack savings, and we take loans, and again we just keep on earning more to pay those EMIs. But what should be the goal? The goal should be we should earn, save and then spend. Never the other ways, that earn, spend and then save. We need to understand that what are the real products of need and what are the products of prestige. So if we can really understand the products of need and the products of prestige as 2 different things, probably we will start spending on the products of prestige and maybe save for products of need only. Now taxation is something which is important. We need to know a lot of different ways by which we can save tax legally, because the more we save tax is something which we can divert those that saved money to investments and can generate more wealth. I'm not going in details of different taxations. So it's just a small example that one guy who invests 1,000 rupees from the age of 25 years and saves for 10 years, and other guy saves 2,000 rupees for 5 years. Their investment is same, like 1.2 lakhs. One is over a period of 10 years and other over a period of 5 years. Will end up generating different kind of final wealth. So the first can generate 2.6 lakhs, another can generate 1.7 lakhs. So this is the power of compounding that we see. So if we stay in the game for a longer run, we can compound more wealth and generate higher amount of money. So this is something which is an important concept. We all know that the inflation rate, which has been talked about a lot in the current days, we say that the historical inflation rate in India is around 5-6%. So that, what does that mean? That if we can afford something which is 100 rupees today, after 1 year the price of the same thing is going to be 106. Now suppose we have put money in FD, which gives us 5% returns, which cuts 30% tax. So at hand we are going to get 3.5 rupees at the end of a year. So the same thing which we could have afforded today, buying at 100 rupees, which is now going to be worth 106 after end of 1 year, with that FD returns we are not going to afford. So of course that's not going to be a good way of creating wealth. So we need to understand that there are 3 basic understanding: wealth creation, wealth protection and wealth destruction. So anything which gives less than 6% returns is wealth destruction, but anything which is more is going to probably create or protect wealth. Then there is basic understanding in investment as diversification. We need to have 4 different products where we need to diversify our money. So there is gold, real estate. I think real estate we need not much talk about because most of us are going to have some investments in real estate, equity and debt products. Maybe at a age of around 40 to 50, that percentage distribution can be 10%, 40%, 40% and 10% in GRED. And that is something which is important from diversification point of view. Now this diversification is important because it diversifies your risk, it diversifies your liquidity, returns and time. Because every product will have different kind of risks in terms of liquidity, returns and maybe other things as whether there is a risk or like equity will have higher risk but higher returns, debt product will have lower risk but lower returns. So we need to manage all these, diversify into all these 4 products and then go ahead. Knowing oneself is very important, so we need to know whatever we call it as target. So that is time, how much time we have for this investment, what is our age, what is our risk appetite, what is our goal, because all your investments need to be goal directed. So suppose if right now I see my son is say 6 years old and I am looking for his MBBS admission 12 years down the line. Today if that MBBS admission is going to cost me 1 crore of rupees, I am going to see that with inflation rate that is going to cost me 2 crore rupees at the end of 12 years. So if I have to probably plan my son's education at the end of 12 years, I need to probably have generated 2 crore rupees by then. So that goal directed investment I need to do, and right now start planning it. Just last a minute. So for passive investors, we say that we need to start investing in ETFs, which are equity mutual funds which are traded. Mutual funds, we can just choose with certain criteria. We can start investing in safer and good company shares with growing company shares, and we can choose such 20 to 30 companies. We can start doing dip buying. So whenever there is a market correction, we can add up to more capital, and we learn more about fundamental and technical analysis and become an active investor. Now, as WealthCon, we have different courses for all our doctors to get graduated in different kind of ways, as basic investors, advanced investors, share traders, or FNO traders. But the take-home message at the end is financial management cannot be outsourced. We have to look for our own finances, and we need to manage our own finances. Financial freedom will only come with if one creates an asset, as I said, which will help us to generate the amount of income which will sustain for next 20 years. We need to identify true assets from pseudo assets, and we have to save first and spend later. We have to start investing in diversifying our investments in different products. As I said, gold investment can be in the form of sovereign gold bonds or gold ETFs. Equity investment can be in the form of ELSS, equity mutual fund, ETF, or actually in shares. We have to graduate from this to direct stock investment, and we have to stay invested for a longer duration. So these are the basic key points what we need to remember. Now, how do we do that? Now I'll say that we can join WealthCon. This is an open group, open forum for all doctors, so everybody can be part of it. We need to start reading, studying about investment. Time management is important, money management is important. WealthCon gives us cognition and courage about knowledge and courage about these investments. Capital, of course, we have to put in. We need to have patience, discipline, and faith. And WealthCon teaches us money, mind, and risk management. So that concludes my session, and really thank you all for listening to my talk.
Thank you very much. We are seeing lots of money plants this morning. Has shown us the way. So it's very informative. Thank you. Thank you.
So one small note, when somebody told me that okay, probably you're giving money plant, I just said, who's going to water it? So, WealthCon is like we are giving money plants, you need to water it. Capital needs to be yours.
I request chairperson to felicitate our speaker. I request Dr. Joy Shankar Jana to felicitate our chairpersons. And I request chairperson to felicitate me, the coordinator.
So my topic is need for super specialization. The word super specialty is actually a misnomer. It is actually a subspecialty. And why it is important to acknowledge the correct word? Because it helps us to define the significance of subspecialty in any branch. Anesthesia is a broad specialty in which general anesthesia has versatile options to excel in a particular type of cases. General anesthetist has to deal with a system of human body right from anatomy, physiology, biochemistry to applied medicine and surgical aspects. Having said that, it is seldom cumbersome to assimilate excellence and skill sets in all aspects of broad specialty. And even if one tries to practice it, it might take him or her years of experience to achieve that feat. So arises a question, is there a need for super specialty? Now, anesthesia is a broad specialty and has many subspecialties like cardiac anesthesia, neuro anesthesia and so on. Organ transplant anesthesia has come into picture in recent few years. So each subspecialty in itself focuses on a specific skill set which require dedicated training and specific training in that particular field. Becoming a super specialty is the need of hour because due to rising complexity in diseases and other medical problems, it encourages patients to seek opinion of the specialist than general practitioners. So just few reasons for super specialty degree are a burning passion should be there. There should a boon for evolving medical care and elevated need for a specialist, and patient care is a teamwork. So there are different specialties which needs to work for patient betterment. Thank you.
My topic is woman as an anesthetist, what is different? In one word, everything is different. At the OT front, we have to face poor surgeon acceptance, marginalization by the co-workers and a frequently changing work schedule. But at the same time, a woman inside the OT empowers the OT environment, emotional reaction to patients, and she soothes by social interaction. Moreover, a woman is more vigilant, has a better perceptual speed and an excellent associative memory. At the same time, unfortunately for a woman, the biological demanding age coincides with the career peak and she has to balance both work and the family simultaneously. At this point of time, she needs an understanding and compassionate environment to sail her through the parenthood. We are here not for the battle for supremacy, but to render our anesthesia services for a better patient outcome. So let us welcome the feminization of our anesthesia fraternity wholeheartedly. Thank you.
Our next speaker is Dr. Rashmi Vaimbe.
Good afternoon, everybody. No, I am not prepared any slides. I am Dr. Rashmi Vaimbe. I'll be talking about life in OT without lines. So when I saw this topic, the most important thing in front of me was a monitor. So definitely I would like all sorts of curves, notches, angles on my monitor, and definitely no straight lines if I want life. Secondly, for a person who is prone to tripping like me, I would never like to have gas pipelines or electrical lines on the floor in my OT. So, and lastly and the most important lines which we deal are the IV lines and all invasive lines. So if there are no IV lines, I think there will be no me and no life in the OT. So to conclude, if we want life in OT, I would like to have my patient in a horizontal line, me in a vertical line, no lines on the floor, and no lines on the monitor. Thank you.
That was a great performance by all of the contestants, and I wish there were many more of them because I think this is certainly the most enjoyable part of the conference. Thank you very much, organizers, for inviting me out here.
I request Dr. Sunita Khedkar to kindly felicitate Dr. Madhuri ma'am.